I very commonly get kind of that raised eyebrow, like, well, okay, yeah, I've heard of nitric oxide, and I know some guys are out there taking, L-arginine or this or that. So why is this actually written in as part of a published protocol? And I have to go through the explanation. And I really kind of lay the foundation for them in terms of what the dietary nitric oxide does.
Hi, functional friend. I'm Brendan Bermeyer, the Director of Clinical Operations and Education at Berkeley Life. Welcome to a special episode of the More You Know series featuring a clinical grand round. The More You Know is a monthly webcast bringing you the latest insights on the importance of nitric oxide and blood flow for optimizing the body's natural healing systems. In this special episode, we feature a key leader in the wellness industry presenting a clinical case and a treatment plan that you can apply in your own practice. Don't forget to like, share, and subscribe, and visit berkeleylife.com for more information. Now let's get started. All right, functional friends, welcome to the Berkeley Life Clinical Grand Round series. As always, I'm your host. I'm the Director of Clinical Operations and Education. My name is Brendan Bermeyer. And today I have the pleasure of getting to interview one of our good friends at Berkeley Life, Greg Mcketrick, who is a pharmacist with an expertise in using nitric oxide in all sorts of therapeutics to help his patients with erectile dysfunction, sexual health. So Greg, how are you doing today, my new friend?
I'm doing great. I hope you are.
Absolutely. It's really a pleasure to have the opportunity to work with you and collaborate with you. I love the work that you're doing. And I'd love to give you the opportunity to explain to our audience a little bit about your specialty, which I found to be very fascinating myself.
Sure. I've been working primarily with men's health, but sexual wellness for both men and women for a number of years. And in doing so, I've always been looking for what advantages I can offer patients and prescribers as well. So if we're going with basic therapies, is there a way to augment that therapy? Or if we've gotten to a point in therapy where we're starting to hit some roadblocks and we need to get over a plateau, how can we facilitate that? I met the folks from Berkeley Life. Gosh, it's got to be probably, I guess, 9 years ago now. And prior to that, for years, I had worked with different nitric oxide products, incorporating them into therapies for erectile dysfunction and sexual dysfunction. For the most part, those were amino acid based products, so the L-arginines, the citrulline. Went so far as actually even incorporating them and compounding them into combination medications with PDE5s, medicines like sildenafil or Viagra and Cialis. Never got a heck of a lot of bang for the buck, I guess you'd say. And then once I found the Berkeley Life product, it just made sense. The chemistry going with our own physiology, and it immediately impacted therapies. So I introduced it in combination with a lot of our basic consults and our treatments. It was dramatic in terms of response. So we were seeing not just return business, but people literally walking in, offering testimonials, and people being able to migrate off of more intensive therapies, going to more basic oral PDE5 medications or sublinguals because of the augmentation with the Berkeley Life. That preceded a development that I had. I was working with a lot of patients, doing a lot of training and counseling on referrals from urologists for patients who had fairly pronounced and long-standing erectile dysfunction. And one of the things that struck me in the course of a lot of these therapies was the very common bottom line with a lot of these patients. A lot of them were post-prostatectomy men. So they'd had prostate cancer, and they'd either had a robotic or open prostatectomy, or they'd been treated with radiation. And they were showing up for a consultation. Some of them were 6 months after they had finished treatment. Some of them were a decade or more. And that really kind of started ticking boxes for me. And I thought, man, these guys are walking in and, they have problems with incontinence. So, think about being in Depends or some type of a diaper for 10 years, no sexual function, no erectile function,
Mm.
um, really dramatic effects on their self-esteem and quality of life. So at that point, I developed a penile rehab protocol, which um, it was then published and is used now around the country. And I've been using it with urology clinics and patients now for the last 6 years. So one of the key factors to that was every single patient that was initiated on this therapy. Part of the key elements here was starting them on a PDE5, which was a daily Cialis
Mhm.
to help to kickstart the blood flow. But in addition to that, as part of the prescribed therapy, they're taking Berkeley Life nitric oxide along with that. They're also using a vacuum pump. We're also doing exercises for incontinence, and there's more intense therapy that goes to it. But the main and the baseline therapy that we initiate in all of them is the nitric oxide with the tadalafil. And it's amazing when I present that to urologists. I very commonly get kind of that raised eyebrow, like, well, okay, yeah, I've heard of nitric oxide, and I know some guys are out there taking, L-arginine or this or that. So why is this actually written in as part of a published protocol? And I have to go through the explanation. And I really kind of lay the foundation for them in terms of what the dietary nitric oxide does, and the difference between this product, especially most of these patients, they're kind of past the age where they're going to have fully functional NOS pathway for L-arginine conversion. So it just makes a lot of sense. And it's funny, you kind of see that little light click for these docs as you're going through the explanation. And like I said, it's been very, very successful for me, and very gratifying because of the fact that we see the outcomes. We see what happens with these patients as they're going through this recovery process. Um, and again, because of the success of the program now, like I said, it's up on a national platform.
Yeah, as it's such a powerful synopsis that I get excited about as an educator and practitioner myself. And there was a lot of powerful components to that overview. With my personal background is more sports nutrition, so like it's all about the L-arginine and citrulline and whatnot. And I don't know that I can really say I ever noticed any major sort of performance benefit in that way. But to your point, the science checks out. I'm even in the role that I'm in, I am finding most clinicians are not yet familiar with this nitrate pathway. Most they've heard of nitric oxide, they understand vasodilation, they've heard of L-arginine, they've probably dabbled with it, but maybe not seen those clinical improvements. But then they get exposed to the nitrate pathway, they get exposed to the science of it and the oral microbiome, the whole reduction capacity, which is so fascinating and then so potent. And so I'm curious, as we start taking a look at this case study and this amazing protocol you've developed, some of the literature that I've pulled, not that, I'm definitely not a sexual health specialist, not my area of expertise by any means, but as I was pulling some of the research on, PDE5 inhibitors and nitrate, I think, more research is needed in that area, certainly. Because some of the papers will almost suggest there's a contraindication there, which I think there's a nuance that has to be acknowledged with, okay, we know that nitric oxide stimulates cyclic GMP. We know PDE5 decreases the breakdown. So I'd be kind of curious of hearing a little bit of sort of that art of titration that you're doing with your clients or patients in regards to kind of getting that proper dose of nitrate that's going to be complementary, with the dose of the PDE5 inhibitor. Because I would imagine, there might be a little bit of a delicate balance with pushing more nitrate and more nitric oxide, and then having that imbalance in concert with the PDE5 inhibitor.
Well, the big caveat and the thing that we always have to explain is, there's different types of nitrates. There's organic and there's inorganic nitrates. And it almost is a bit of a misnomer because what we're offering is a dietary nitrate. And in effect, these are inorganic nitrates. The organic nitrates, nitroglycerin, nitrostat, monokit, isodil, these are the prescribed nitroglycerin products that are contraindicated
Mhm.
in use with PDE5 medications because they can induce a hypotensive crisis, or basically they can make somebody's blood pressure plummet through the floor, and they have a real issue.
Yeah.
We don't have that problem with the inorganic nitrates. Again, these are very natural based, so you could achieve the same result if you really ate a very healthy green diet. And I present that to patients on a routine basis. In fact, I typically initiate conversations that way, where I'll explain to them, there are dietary pathways to do this. And you typically get the kind of cross-eyed look saying, you mean I've got to eat all this, or I can take these 2 capsules?
Mhm.
Like, okay. So, we've kind of come to our understanding that, the convenience and the ease of being able to do this outweighs going and, eating farm to table. Um, I don't see a whole lot of issues where we are over balancing in terms of the amount of nitric oxide we're getting from the supplements. Um, I do at times counsel patients in terms of the timing of their dosages. The nitric oxide, obviously, this is something that the body does metabolize out. So I will counsel them based on what their lifestyle is. And, a lot of my consultations are extremely personal,
Mhm.
where we get into, are you someone who has sex in the morning? Are you more of an afternoon? Are you more of an evening? And we'll tailor their dosages and when they take their medications and supplements more around their typical lifestyle and what their rhythm is. So we don't see a whole lot of problems in terms of getting too much. We actually have patients where they will take daily their supplement. They might take their 2 capsules in the morning, and then on days when they are anticipating that they're going to have sexual activity, they'll actually duplicate the dose later in the day, just so that they have peak levels in their system.
Perfect. Perfect. I think it's an important point to delineate because, often I'll be talking to practitioners and, we get some of those raised concerns. And to your point, I always will reflect it back to them with kind of the salad analogy of like, well, it's dietary nitrate. So it's really no different than if you had your patient or client drink like a big, spinach juice or kale juice. I was just drinking a green juice yesterday, and sure enough, it lights up the strip nice and pink about 90 minutes later. So when you reflect that back, it gets the gears turning a little bit. So that's kind of a perfect segue then into, we can talk about this case study that you actually published. And did this specific case sort of pave the way for the protocol that you developed, or?
No, actually, this was after I had developed the protocol. And again, the protocol itself was developed out of a real gap, a real need in terms of care. And before I went to the point of producing this and then publishing it, I met with a lot of my partners in urology clinics and really sat down, and we hashed out the fact that these patients need a comprehensive pathway. We need to be able to offer them a better way to approach rehabilitation. So the protocol had been penned already. We'd already developed it. And this was one of the, I wouldn't call it a test case necessarily, but it was one of the earlier cases. I was approached by one of the clinics that I worked with routinely. And, you know, what's always very striking to me is when you're approached by the medical provider and they almost give you the shoulder shrug, as in, I don't know what else to do. We've kind of done what we can, so I'm going to punt it to you. And initially, a lot of times that was what the response was, and then as they saw the outcomes of the patients, it became more second nature for them. But this was a situation where we'd already developed the protocol, it had it in workings, and this particular clinic ran into kind of a roadblock with a post prostatectomy patient where they literally were kind of shrugging their shoulders, saying they didn't know how to proceed.
Absolutely. So then with this specific case study, if you want to give us a little bit of background information on the patient, I mean, sounds like a sort of prototypical example of what you'd really developed the protocol for.
Yeah, and again, this patient had presented and went in for what's called a Da Vinci or robotic prostatectomy.
Hmm.
Um, with my protocol, my request to providers is that they actually refer the patient over prior to procedures because that
Hmm.
allows me to work with them on exercises for continence, for Kegel exercises, core strengthening exercises before we ever get to the procedure. We want to develop muscle memory and
Hmm.
really kind of give them the skills that they're going to need to facilitate recovery and continence after the effects. So this particular patient was referred after the prostatectomy.
Hmm.
Um, we had minimal issues in terms of dealing with incontinence with them at the beginning, but they were having literally no response whatsoever in getting erectile effect for the patient. Um, in fact, after he was referred, and this is again, this is one of those heartening issues where I literally had this patient come in for consultation, and the first thing that came out of his mouth was, if there's really no help for me, I just prefer you tell me right up front.
Yeah.
Um, and that just kind of goes to show how necessary this type of therapy really is, because what ends up happening is patients, they wander down this path. They're using the internet, Dr. Google, trying to find answers, and when they get minimal benefit from the assistance provided from their provider, their medical team, it becomes even more frustrating, and it leads to depression. It leads to a lot of negatives. So the sooner I have contact with them and have the ability to start the consultations, the better. And then again, this was a situation where we were able to get this fellow started, and we initiated the basic principles of the protocol. We got him started, and especially someone who's coming to me after the fact, and he's had a few months where there's been no erectile function, there's been no response whatsoever. Then it's even that much more important for us to really kickstart that blood flow. We have
Yeah.
to get the blood vessels reperfused. So starting that therapy, getting the nitric oxide in the system, getting PD5 in the system, and then we couple that with physical therapy using a penile erection device or a vacuum pump as physical therapy. So not only are we increasing circulatory function and blood flow, but we are forcing that blood. We're pulling the blood into the vasculature using the vacuum pump. And by doing this, not only do we reestablish blood flow, we reperfuse that tissue. We also are able to restore the elasticity to the tissue because just like someone who works out frequently, when you stop going to the gym, the term is you use it or you lose it, and it's
Right.
true in this case also. So we need to get the ability to achieve and the frequency of the erections back as quickly as possible. Once we've kind of gone through this mechanism where we now have established good blood flow for the patient, and the patient is able to achieve erections, even if it's mechanical using the pump,
Hmm.
then we can start to initiate some of these a little bit more invasive therapies to really address that erectile function. One of the factors with all of this, and part of the protocol, we have a very intensive intake process. There are some different uh, tests that are commonly used by urologists. One is a SHIM test, or a sexual health inventory for management test.
Hmm.
I modified this to my own purposes and use it to establish the history, because I have to know prior to the onset or diagnosis or treatment of the prostate cancer what the patient's situation was. And then based on that, that gives me a better understanding of what therapies are going to be necessary after the fact. There's a lot of differences with these patients, and someone who comes into a diagnosis of prostate cancer is facing prostatectomy or radiation, who is a longstanding diabetic, or already is on blood pressure medications, or is taking SSRIs for depression. You look at all of these different components, and then that really guides the pathway once we get to the point where we're really addressing the rehabilitation. This gentleman responded well to combination therapy. Again, I think really what the significant difference between what the uh, urology clinic had attempted, they did nothing in terms of really restoring that tissue, getting the blood flow started again, um, doing that rehabilitation portion of this work. Once we got through that process, and it takes for most men, it's several weeks to a few months of
Mhm.
doing this until we really see the benefit that we want. Then kind of triggers us. Okay, we're ready for the next stage. And
Mhm.
this particular gentleman had gone through, and we initiated a couple of different levels of therapy. Ended up with a what's called a penile injection,
Mhm.
which is a injection using little insulin needle vasodilators into the corpus cavernosa of the penis, the chambers within the penis. And this was kind of the golden ticket for him.
Mhm.
And this allowed him to be able to maintain and achieve the results that he'd been looking for. Now, he stayed on the nitric oxide throughout the course of this because there's significant benefits in terms of how that functions, even with those vasodilators. So again, this was one of those kind of perfect scenarios where, because we were able to implement the basic steps and really start him down this path, the results turned out very well.
Mhm. Mhm. Amazing. You answered everything pretty well there, because I was curious, maybe like a rough percentage of, how many of these patients usually respond well to the initial dietary nitrate, physical therapy, and PDE5 inhibitor versus maybe how many of them have to move on to the vasodilation injections, or how do you determine that?
And again, it really is one of these things, and I'm not going to say that I've got a crystal ball, but when
Hmm.
I have that intake consultation with them and I look at their history, if I have someone who presents to me who, number one, is in good physical condition, they're not overweight, they're not, fighting hypertension, they're not diabetic, and they report that prior to prostate cancer, they were taking no medications for erectile dysfunction. That patient presents with a much clearer path, and we are probably going to see faster response, response with less intervention.
Hmm.
So a lot of times we'll actually see these patients, they'll initially respond to the PD5 nitric oxide. A lot of them will report back that after a few weeks of that with the physical therapy using the vacuum pump, they are starting to notice that they're retaining erections even after the pressure, the vacuum of the pump is gone. And this is one of our indicators. We have several indicators that we look for: spontaneous erectile function, nocturnal erections, and the ability to maintain an erection without any further stimulation.
Hmm.
So we start to see some of this start to appear, especially with these guys. You call them the poster child when they come in, because again, they were in great condition uh, at the beginning, and we just obviously we're going to see generally a better outcome for that patient. When we see patients that come in who had some issues um, prior to their diagnosis, we are pretty well aware that we're going to probably have a little more complicated pathway.
Hmm.
The thing that I tell every one of these patients: doesn't matter what their starting point is, because we have the capacity to incorporate, I call it building block therapy, where we start nitric oxide, we start the PDE5, we start with the vacuum pump, and then we start to layer on. So a patient who starts to show a good response from initial therapy using the nitric oxide and the PDE5, they are a good candidate to very possibly avoid having to go to that penile injection. Now, we may need more aggressive medication than just the tablet, the PD5 tablet and the nitric oxide. We use combinations that, as opposed to oral tablets, we use a sublingual, it's called a
Hmm.
troche, where the medication is delivered not only at higher concentration, at a higher rate of absorption, so greater bioavailability. In addition to that, we can combine different entities into a single dosage form to achieve maximum benefit for the patient. So a lot of patients we can use that step. And one of my philosophies is I'm always going to use the least intrusive methods first. Um, it does two things. Number one, we're not skipping any steps. I unfortunately run into practitioners, urologies, especially the surgeons, um, who are very quick to pull triggers with these patients. They'll try an initial therapy for them, and if it doesn't work, they automatically go to this conversation about a surgical penile implant.
Mm.
And I'm always pumping the brakes, saying, guys, I'm not saying that that eventually won't come into the picture, but boy, we're not even close.
Yeah.
And from the psychology aspect with the patient, if you bypass and automatically jump to kind of the final solution before you've kind of walked through the equation, what you're doing is you're eliminating, number one, their thought process in terms of this and their ability to really wrap their head around. When we go step by step, it allows them to see, okay, we tried step one and this was the effect. We moved to step two and had some benefit, but not quite there. We moved on to the injections, saw the effect we wanted. When you do that, it answers questions because a lot of patients are resistant initially to go into the more intrusive therapies. If you offer up and allow that test with the less intrusive therapies initially, they're much more open to the conversation when you come to the point where you say, we've tried everything leading up to this. This is where we're at. Not saying that's where we'll end up finally, but at least at this point in recovery, this is where we're at. A lot of patients will initially have to go to penile injections and then down the road because the process. And again, I've kind of bypassed this, but with any type of prostate surgery, the ideal outcome is that both nerve bundles. There's nerve bundles on both sides of the prostate. They are both spared in the process. Many times they are not. And ideally, the report we want to see at the end is fully nerve sparing. But that's a little bit confusing because even in nerve sparing surgery, those nerves will be stunned. And with the nerves stunned, we have very little response. And it can take 18 months to 2 years for those nerves actually to fully respond. The sooner we begin rehab, the faster they respond. Again, a key element in getting them started sooner. But a lot of times in that interim, while we're waiting for those nerves to fully recover, we're using a little more aggressive therapy. And then as the nerves start to respond and wake up, we can back off of that and use some of these less invasive therapies again.
Mm-hmm. Perfect. Such a perfect outline there. And it highlights just how important that clinical intake is, being very thorough, and also helping kind of create that roadmap to empower the patient and perhaps most importantly, to set the healthy expectations. I think in today's world of instant gratification, it gets lost in that. And that's kind of the art of being an effective clinician, to set those expectations of, let's start with, minimal effective dose, least invasive. We can obviously scale, titrate up. I'm curious with the, oral or the troche or troche with the PDE5 inhibitors versus the penile injections. Is it kind of one or the other, or sometimes a combination of?
So a lot of times I will do combinations. I typically won't use a combination of the troche along with the injection, but in many cases, they will stay on the nitric oxide perpetually.
Sure.
Many of them will stay on that daily Cialis, and then we'll start to introduce very gradually the more invasive therapies like the injections. Um, the main reason that I emphasize this, and again, this is another point of contention a little bit with urologists because they have been instructed forever. You never use a PDE5 in injection because you're literally setting up these patients for priapism or erections that won't resolve.
Sure.
The way I work, I do things very carefully and make very, very incremental changes to things. I use minimal doses, as you mentioned.
Mm.
So even if I'm doing combination therapy, I'm doing it in a way where I'm very cautious in terms of any extensive duration of effects. making minute adjustments to therapy until we get to the desired outcome for the patients. Um, Using the tablets, nitric oxide with the troche, that's extremely common. Using the tablets of nitric oxide with the injection, that's extremely common. Typically, the troche and the injections, that's pretty aggressive.
Sure.
So that's not typically going to be one of my options coming out of the gate.
Yeah.
Not saying that there won't eventually be a call for it, but that is certainly going to be something that we're going to wait and see before we would go to that.
Sure, sure. And you mentioned it before, and just for the benefit of the audience of clinicians, some patients might respond very well within weeks, others it might take months, especially if there's more nerve damage. To your point, what would you say maybe in an average, again, obviously I know this is very nuanced and bio-individualized, but maybe like an average time frame that you're working through this protocol? And then part two to that question is, what does a maintenance regimen look like onwards once they've reached sort of that level of functionality that they want, they feel good about? Is there sort of a maintenance phase that perpetuates that, or what does that transition look like?
So just to kind of jump in on that, the
Yeah.
initial course of the protocol, we're looking at about a 5 month course where
Okay.
I literally have a monthly consultation meeting with these patients. Through the course of that, what we're doing is we're checking boxes in terms of the milestones that they're hitting. As they progress through, we are intensifying their care or we're maintaining them based on the progress. A lot of this is very individual based on the patient.
Yeah.
Some patients, they're satisfied. Actually, some patients are very satisfied with, being able to achieve the erection and maintain it using a vacuum pump and a retention ring. And they're not really interested in going beyond that. That's something that can be achieved very quickly in the early course of therapies. Majority of patients, that is just too mechanical of an answer.
Hmm.
So we will progress them. So what do? We start out with the basics. We use the physical therapy components and the exercise components with the basic underlying medication and supplement therapy for the first 2 to 3 months, and then graduate them as needed. If we graduate patients to troches, this will be, I'm not going to say it's going to be kind of a ping pong match, but we will always be looking to see if they're responding to the troche, can they respond to just the tablet, or do we have to maintain that more aggressive therapy, a little more potent therapy? Many patients will choose to remain on the troche simply because the results are better. It's more efficacious for them. Same basic concept goes if we graduate them to the injections. Patients who graduate to injections, you have a fairly clear indication in terms of whether they're going to be uh, dependent on that going forward based off of what type of formula they respond to. And this might seem a little confusing, but in these injections, I've probably formulated 150 different combinations based off of patient needs over the course of the years.
Hmm.
If you get into a very aggressive therapy, higher concentrations, and that is maintaining the patient, their chances of coming off of that and using kind of the more basic therapies isn't great. And there's a lot of reasons for that. Some of it is age, some of it is nerve damage. Some of it can have to do with other physiological issues. There's an issue called venous leak as men get older, and especially if they have any kind of challenge to their vasculature. This is where physiologically their anatomy, they cannot retain the blood in the penis. It literally leaks out.
Hmm.
So it's very hard to overcome that. And again, these are things that we work with through the course. One of the things that I tell people is there's probably 20% of these guys who will return. They'll have natural function without any real need for additional therapies whatsoever. There's another 30% who are going to be maintained using the nitric oxide, tadalafil, and that will really kind of give them what they want. And then the other 50%, we're using more aggressive therapies. And generally speaking, we're probably looking at that long term.
Mm-hmm. Okay. Okay. Makes a lot of sense. I think a lot of clinicians that tune into this will really be able to benefit a lot. And I'm curious, but I'd love to give you the opportunity to talk about this particular patient, the results he experienced, and even, it was in the publication, which was amazing to read. Even his care providers were astounded by the results. And I'm curious to hear more about that. And also then we can talk about, how can other clinicians that really want to get trained in this protocol and learn more about how to do this, where they can learn how to do that?
So the easy answer in terms of the clinicians, I wish I had this back when I initially wrote the protocol, but of course, it takes time to develop things. We now have a website called penilrehab.protocol.com. Thanks to the resources of Revelation Pharma, we were able to pull this together with a lot of the collaborative partners, including Berkeley Life, but other companies like Boston Scientific and Gainswave. Also Zero Cancer, which for those who are not familiar, Zero Cancer and us too, those are the prostate cancer support networks that are all over the country. I speak to their groups. I've spoken at their national forum. So these are all contributors to this site. In addition to that, I have all of my training material that we've actually developed over the years. So information about nitric oxide, information about PDE5s and troches and penile injections, how to use a vacuum pump, how to implement a penile rehab protocol into your practice. One of the things, and I just returned from the American Urology Association conference, which is phenomenal. 12,000 prescribers in attendance, and every cutting edge surgical approach and medication approach, pharmaceutical approaches that exists. And one of the things that I can confidently say is that I don't think there's another pharmacy that is working with this kind of a protocol. Some of the clinics incorporate these in, but from the pharmaceutical side, it's a little bit different simply because I think the understanding of the pharmacology and how to implement these changes and the different layers as you're building through this is something that does take some time. And one of the reasons why, when I'm working with the prescribers, they seem to really prefer being able to have at least a handoff in terms of, hey, what therapy do you think is going to be most effective at this point? And I think that's really pertinent in terms of this case with this patient, because really the short and long-term prognosis with the patient, the short term was, the doctors had pretty much thrown their hands up. And unfortunately, that really is conveyed to the patient. So the patient they present to me almost with that mentality that they've already lost the race. And, one of the things that I try to emphasize, again, we do a lot of consultations with these patients, and I make sure that they understand this is a process. It's not a golden ticket. This is a pathway. So there's definitely a light at the end of the tunnel. We're going to get you to that light. Yeah. It's just how many steps do we have to take along that path, because all of this is individualized.
Yeah.
This particular individual, again, it took some tweaking in terms of formulas. It took a little bit of adjustment in his therapy. The great thing was, he came out of this with full function, with continence. And I guess my biggest thing with this is, restoring quality of life to a patient, and not just the patient, but the partner that's involved in this as well. Yeah. I have a sexologist that works with me with protocol patients, because in many instances, especially where there's long-standing issues with erectile function or sexual function, there is an absolute breakdown in intimacy in the relationships. So, I am privileged in that I get to see this progress that the patients and their partners, their spouse, really kind of move through this and come out that other end. Um, it was certainly true with this particular individual. And I think that's where working with different prescribers, the fact that this is more of a holistic approach to really what's best overall for the patient, what's going to ensure the best outcome, how that benefits the prescribers. Number one, we're taking a lot of the load off of their plate because, every one of these patients that we're working with and we're spending all this time in consultations and doing the adjustments for, that frees up that doctor to see more patients, perform more surgeries, whatever the case is. They are being updated constantly with the SOAP notes and the progress notes on these patients, and they're adding those to the charts. In addition to that, when these patients are satisfied with their therapy, well, that increases patient retention for the office. So again, that's a benefit. The other side of this is that a lot of these patients downstream will become surgical candidates at some point, whether it's unresolved incontinence, where we're making references and suggesting back to the physician, patient is a surgical candidate for something like an artificial sphincter or a sling, or even further down that pathway, as we discussed earlier, some of these patients will either for reasons of their own physiology or due to medication therapy, or just the fact that they kind of get to a point where they just don't want to use medicines anymore, they'll become a penile implant candidate. So we keep that pipeline open between the patient and those clinicians, constantly keeping a finger on their pulse, knowing exactly what's going on, maintaining them at the best possible levels. It's great for the docs, it's great for the patients, and certainly, it's extremely gratifying for myself, being in the position where I get to work with them and really see the benefits.
Absolutely. Such a well-rounded and eloquent way to map all of this out, because I think the need is greater than ever. And I have the utmost respect for anybody that's able to identify this needs gap, this kind of healthcare deficit, if you will, and create a solution that isn't just, this black and white, one size fits all protocol. There's an art to it. Everything from the coaching psychology, the envisioning, the goal setting, the overcoming obstacles together. It goes so much more beyond some prescriptive model, but you're really, like you said, empowering them, you're giving them quality of life back, and then you're seeing the impact it has on them and their partner and their family. So I listening to this, I find it all extremely touching. I think the work that you're doing is outstanding. And of course, then it's very exciting too, with, of course, the work that we're doing at Berkeley Life, trying to advance nitric oxide research and this nitrate pathway research. So it's very exciting for us to see, the clinical application and the efficacy and how these, Berkeley Life nitrate therapeutics can really be used, especially within this growing area of concern with sexual health dysfunction. So certainly we really appreciate the work that you're doing, and we'll obviously be including your publication, which was amazing to read, your website for the resources, and our show notes. So we greatly appreciate you coming on today. Thank you for joining us. If you enjoyed this video, don't forget to follow for more insightful wellness content from Berkeley Life.